On behalf of EXCHSA, I would like to welcome you to this industry-sponsored symposium hosted by Berlin Heart, titled EXCOR Revive, Shift of Perspective for Failing Fontan Patients. But before you start the symposium, I would like to extend the thanks of our association for the continued support from Berlin Heart to us, and especially to this meeting that had to be held in this format. Thank you very much, and I give the word to you.
So thank you much for the opening words. My name is Zimpfer. I was invited by Berlin Heart to present on the EXCOR Revive Fontan cannula for patients with Fontan palliations that have to go heart transplantation. This symposium is co-chaired by Professor Hörer from Munich and also Professor Hübler from Hamburg. So these are my disclosures. Obviously, the Fontan palliation is the standard treatment for different forms of univentricular heart disease. The worldwide population of patients that have been palliated with this approach is ever growing and is estimated to be around 70,000 patients, with almost half of the patients above 18 years of age at the moment. The survival after the Fontan palliation per se is very good, and most patients nowadays will become adults and live an active life. However, there is an ongoing hazard of developing either failure of the ventricle or failure of the Fontan circulation, and currently around 80% of patients are expected to live after 30 years. When we analyze the transplant-free survival after the Fontan operation, what we can see is that the hazard of transplants goes up after the first decade after the palliation, and one can speculate that the incidence will become higher. In analyzing the different types of Fontan failure, it has to be appreciated that we first of all see a typical heart failure, which is caused by the failure of the ventricle and is often also termed subaortic failure. This type of heart failure is very similar to what we see in patients with biventricular hearts that develop failure of their ventricular function. Then on top, and this is the second form of failure, we can also appreciate that there's subpulmonary failure, which basically is a failure of the Fontan circulation itself. And this specific entity is characterized by heart failure despite reasonable ventricular performance, simply as a consequence of venous hypertension and its end organ consequences. The typical symptoms, and we are familiar with that, are related to overload of the lymphatic system, plastic bronchitis and losing enteropathy, and venous congestion. And one of the most important manifestations of this kind of failure is Fontan-associated liver failure. This is the typical phenotype of a patient with Fontan failure. You can see the large abdomen. Patients usually are sarcopenic because they are in prolonged heart failure. They have ascites and they become intolerant to exercise. The standard therapy for patients with terminal Fontan failure so far has been heart transplantation, which of course comes with a lot of limitations. The first limitation is the only limited availability of donor organs, and the second limitation, and this is especially important when we analyze the risk-benefit ratio of transplantation is survival after transplantation, which is significantly worse in those patients that are presenting with Fontan circulatory failure as compared to subaortic failure. So far, there have, of course, been a lot of attempts to support the Fontan circulation with different, basically constructs of extracorporeal support or mechanical circulatory support, but no dedicated system has been developed. What surgeons have been performing so far, and these are drawings that kind of mimic the initial description of Rein-Repretref or subpulmonary support, is to create the venous reservoir into the former Fontan circulation, which then is connected to a Berlin Heart system, and this is the inflow, and the outflow goes to the divided extracardiac conduit, and this can of course be initiated as forms of isolated subpulmonary support, but also combined subpulmonary and subaortic support. In recognition of the technical challenges and also of the complexity of the procedure, when the Berlin Heart is implanted in this fashion, Berlin Heart started to develop a cannula that is dedicated for implantation in the subpulmonary position and dedicated for support of the subpulmonary circulation in patients with Fontan failure. This is an initial development, and there have been several iterations so far, and at the end of the day, the cannula will be available in different sizes to match different patient anatomy and also patient size and weight. What is important when we start to apply this cannula in humans and start to treat our first patients is that we have to recognize that the anatomy can differ very widely. So we can face different anatomic challenges that first of all relate to the construction of the Fontan pathway, but also to specific anatomic details of different patients and patient size and weight. So these are some initial pictures of preoperative 3D CT reconstructions and virtual fittings for patients that were screened and also treated with this new cannula. At the end of the day, the cannula can be integrated with the standard Berlin Heart system, so it also works with the EXCOR Active. For the outflow cannula, we can use the standard Berlin Heart cannulas, but also the new Kraft cannulas, and this is basically compatible with the standard Berlin Heart system we are all used to. What this setup allows us, in addition to supporting the subpulmonary circulation, is to kind of create a pulsatile perfusion of the pulmonary vasculature, which at the end of the day could also serve as a training of the pulmonary vasculature before heart transplantation, especially in those patients that have small pulmonary vessels that certainly pose a significant risk at the time of heart transplantation. There have been three implants so far, and fortunately all of those implants have been highly successful so far. The first patient was implanted by Professor Hörer in Munich. It was an isolated subpulmonary implantation. Here you can see pictures at different time points after a very successful surgery. And what you can already appreciate when looking at the pictures is that this system really allows for recovery of these patients and in-hospital rehabilitation, and the patients certainly become better transplant candidates. So this patient was a 17-year-old male in Intermix level 2 with hypoplastic left heart syndrome. He was implanted in February 2021. The case was initially discussed in an expert call in February. The implant was then done early February, and the patient has now been transplanted and is doing very well. The second patient is a patient that was implanted in Vienna. It was discussed first in an expert call in October 2021. It was also a patient with hypoplastic left heart syndrome, was a patient in Intermix level 2 that had several previous procedures and was also supported with an ECMO system for a short period of time, which was successfully weaned, but the patient remained in terminal heart failure, and the patient was implanted in October 2021, recovered very well. His end organ function completely normalized. Again, you can see the pictures early after the implant and after several weeks of support, and you can appreciate how well the patients recover and develop towards very suitable transplant candidates. And this patient is stable on the normal ward at the moment and is awaiting transplantation, which will probably be soon, hopefully, but the patient has a very complex immunological situation. So we are also looking for a good match in terms of the immunological situation. The third patient was also a BIVET. It was discussed in March this year. Also a patient with hypoplastic left heart syndrome and multiple previous procedures, including a Rascar operation for decompression of the Fontan circulation. He was implanted in March. The patient is stable, is also improving clinically, and will be listed for cardiac transplantation. Is currently paused on the transplant waiting list after a complete recovery, and also when a certain amount of, I would say, rehabilitation, in-hospital rehabilitation is possible. So in conclusion, the new venous cannula offers us a standardized implantation method for implantation in patients with Fontan circulatory failure in a subpulmonary position. What we can already summarize from the patients that have been implanted so far is that the system leads to a rapid normalization of hemodynamics and allows for end organ recovery, and consequently has the potential to lower mortality at the time of transplant listing. And it's probably also very reasonable to appreciate it. It is a system that can recondition the pulmonary circulation to pulsatile perfusion with a normal cardiac output. This might render this system very useful as a concept for patients with a high-risk situation due to small pulmonary vessels. Thank you very much.
Thank you very much for the presentation and the very encouraging, very, very good results that open, I think, new avenues for the care of these patients, the number of which is bound to increase as time goes by, and we all know that. I just wanted to ask whether, if I understand it correctly, it's the size and volume of the new venous cannula that sort of substitutes for the collection chamber. Is that correct?
Yes, that's correct. So, so the cannula itself basically is the collection chamber, and it is then connected to the basically divided extracardiac conduit on the lower side, and to the vena cava superior on the cranial side, using vortex cannulas. So it gives us a certain amount of versatility and also volume. And perhaps Professor Hörer can then also comment on that. But from a decongesting standpoint, it is extremely efficient, because the system really works with almost no negative pressure. So the ability to collect the venous return very effectively seems to be high.
Thank you.
Unfortunately, I cannot see the questions from the audience. I don't know if you have that ability.
There are no questions so far from the audience, but I can perhaps add another word. There were concerns of collapsing cortex extension grafts using this cannula, and that's why in previous case reports, René Pretre, Robert Chesneva, they constructed this new atrium, this venous reservoir, but during the design of the cannula in animal models, it was observed that it was not required. And finally, in those 3 patients, we demonstrated that there is no reservoir function required. It's within the cannula, as Professor Zimpfer said, and we didn't observe any problems with suction or collapsing of the venous pathways. Perhaps because we increased the pump rate gradually, and we allowed central venous pressure to be as high as 10 or even more in the first 2-3 days following implantation. Not really because we are afraid of those collapsing issues, but because we did not know whether the systemic ventricle will be able to adapt to the increased preload, because we had only subpulmonary support. But it was not a problem, and with increasing frequency of the pump, central venous pressure come down, and that was the point where our patient recovered from his end organ failures.
Jürgen, may I ask something? I can see that the volume of the cannula, which is it's of reasonable size, can substitute for the collection chamber, which was sort of devised in the original descriptions of the Fontan mechanical support paper. But would that be the case regardless of the heart rate? In other words, an appropriately sized venous cannula for a small, let's say a failing Fontan at the young age, 4 or 5 year old who for some reason fails. If you put this cannula, but the heart rate needs to be high, would that also support this cannula? Would it also support the collection chamber function?
Good question. I can't answer. I just can comment on our patient. He was 17 years old, and it worked. Patient from Genna was younger, but you didn't observe any problems with that, did you?
No, but I think to address your question, I'm not sure if we have a cannula for very small patients available at the moment. So
what's the smallest size?
The smallest size at the moment is, let me go back to the presentation.
I think it's 14-18.
Yeah, it's 14-18. So it's already, and that refers to the ends of the cannula. So it is already a big, it already is a big cannula. I mean, as far as the connections are concerned, this shouldn't be a problem, even in smaller patients, because we routinely use 18-20 millimeter conduits in 3.5-year-old childs, or even smaller for the Fontan. But what I cannot answer at the moment, and that really then depends on the virtual fitting, is if the cannula itself, so this reservoir, already fits in a patient that is, let's say, 10 kilograms or 10 or 15 kilograms. I think this will really depend on the virtual fitting.
Don't you think that part of this reservoir function is actually situated in the cable veins? They are dilated, and they are that would be their normal function, to be a capitans reservoir. So.
Yeah, that certainly is. I would completely share your opinion.
I would be very interested in the decision tree of decision making. When do you do Raskar procedure? Was it successful? When do you choose or go for single subpulmonary, subaortal assist device? What are the cutoffs? And when do you list for transplantation? At what point?
That's a very tough question, Michael, because I think this is something that is very hard to answer. The second patient, I can only answer it kind of from coming from the backside. So the second patient we did had a Raskar procedure before, and I personally found that quite challenging because the native superior vena cava was extremely small. So the conduit they used to do the Raskar procedure was much larger than the native vena cava super. It seems that that this kind of introduces a process of deconditioning of the native vessel, because probably most of the blood from the upper body after some time goes over this conduit, not the vena cava superior. But I think at the end of the day, the transplant certainly is a very, very good option for these patients when they are eligible and when hearts are available.
So why did you choose BIVAT implantation in both cases?
Because we were not sure if the ventricle is good enough to tolerate an isolated subpulmonary support. So in the first patient from Vienna, actually the discussion was whether an isolated ventricular support is sufficient, but the patient had a very bad situation when it came to his end organ function. And our personal estimate was that if we do the wrong decision and just support the ventricle, this patient would not tolerate the second operation and an upgrade to ventricular support plus subpulmonary support.
Well, thank you very much. Are there any surgical issues you could mention or could address to help others to start such a procedure?
If I may have a comment on that, our patient had 6 previous sternotomies, and so that implantation was the 7th sternotomy. We found it extremely helpful to cannulate neck and groin vessels. So if no cannulas in the surgical field, this facilitated the procedure, I think. Also, we only dissected the structures we needed and nothing else. We didn't see the heart at all, just the caval veins and the pulmonary artery. It was more easy to clamp the caval veins if there are no cannulas in. So I would recommend this. And in addition, it gives a certain safety during chest opening when you have the possibility to go on pump and stabilize the patient. And also for weaning, it's easier.
Jürgen, you still need to dissect out the cava though for doing the connections, correct?
Yeah. But if you have no cannulas in the caval veins, this gives you the 1-2 centimeters. You just need to clamp them and to put the cannula in.
Mm-hmm. You put the cannulas in the groin and advance them under echo guidance or any tips on that?
Yeah.
And also the SVC cannula from the IJ.
Yeah. This is something we do quite often in good surgery, also for conduit exchange, because it's quicker. The procedure is faster, and you really just dissect what you need. You don't need the aorta. And finally, this is a procedure we did on beating heart. We just fibrillated the heart because there was a fenestration we had to close. Fontan fenestration, but the rest of the procedure is beating heart surgery.
What about axillary artery cannulation versus groin cannulation?
We have no experience with that.
We sometimes cannulate the axillary artery, but for the 2 cases we did a regular cannulation, but I can clearly see that the benefits of the peripheral venous cannulation, also for the supravena cava.
Do you cannulate the groin directly with a cannula or via a graft?
We do it directly, either with a skin incision or just percutaneously. That depends a little bit on the patient.
Mm-hmm.
I think we have to end this interesting discussion now. We have 5 minutes before the next presentation.
Doctors, excuse me for interrupting. There is one question from the audience right now.
Let's answer that. What is the question? I can't see the questions.
It is a comment from Ika Matila. He congratulates for this achievement and more or less a good summary for the session. He stresses the point that there is increasing number of patients who will need subpulmonary or biventricular support, and he asked what comes next. So what comes next? Maybe we have a possibility to have implantable devices. What comes next will be the question of organ shortage, I think, because this support is supposed to be a bridging to transplant, and it's not destination therapy.
Do you have any periodically there are updates on innovative implanted devices to support the pulmonary side of the Fontan circulation? Are there any inroads or anything that is in the works from your point of view? You know, Mark Rothfeld in the United States has been working for years on a low impedance rotating pump in the Fontan circuit. Anything in the works at Berlin Heart?
I think that there are several groups that are working on implantable devices to support the subpulmonary circulation. The Rothfeld group, they're certainly extremely far already, and there is also Markus Graneger, who worked together with Michael in Zurich and with me in Vienna, who is a technician who is working on an implantable pump to support the Fontan circulation. And at the end of the day, it will probably mostly relate to the ability to raise sufficient money for this indication that probably is complex when you want to make a business case out of it. And and this will at the end of the day determine if we ever have a system that is implantable and could eventually substitute for heart transplantation, or if it stays the way it is at the moment, that we don't have that we only have the Berlin heart.
And I think this is a very insightful comment, because in the end, in order to develop new technology, one has to invest in it. And at the moment, that seems to be a great difficulty, I think.
And if someone wants to bring such a device into clinic, it's millions and millions and millions of euros of device testing, bench testing, durability testing, and conducting a clinical trial.
Absolutely.
Yeah.
It's very true. Great. I don't see any other questions from the chat. Any other comments, Jürgen, Dr. Hübler, our speaker, who gave a very nice presentation.
Thank you.
If not, perhaps, Morten, we can close this session.
I think we can close this session, and thank you very much for a very interesting discussion.
Thank you.
Thank you.
Thank you very much.
Thank you. Bye.
Bye-bye.